risk factors, and grading and management. Uh, there is a separate class on complication of subarachnoid hemorrhage. So my talk will be restricted and the case also will be restricted only up to primary management of subarachnoid hemorrhage. So without wasting time, let us start with the case. My patient is 44 years old, gentleman. And he is a businessman by his profession, and he is known hypertensive on irregular medication. He was advised to take telmisartan 40 milligram once daily, but he is not compliant to that. And now he presented with complaining of sudden onset of unbearable headache on 14th of July around 9 to 9:30 p.m. Uh, he himself took paracetamol at home, and but the pain did not subside. He had episode of vomiting. And history actually given by his wife later on, and they consulted with local pharmacy and they took some injection, which they can't tell except the injection. They have told that they are giving two IM intramuscular injection of two some injection. But the problem not resolved. She had again episode of vomiting and pain is still persisting. So they decided to take the patient to hospital, but they are from around 30 to 40 kilometers away from this hospital. In spite of going local hospital, they decided to, without wasting time, let go to Apollo Hospital. So they came here around 2:30 a.m. in the emergency department. But while coming to the hospital, patient became drowsy, and the response was delayed. Uh, by history, he was a known smoker, 15 pack years, and regular drinker. But apart from hypertension, he has no known medical comorbidity. He has no history of prior hospitalization or any significant surgical history also. There is no history of fever, loss of consciousness, trauma, particularly head trauma, neck pain, chest pain, or abdominal pain. His family history also not that significant.
Okay,
And here,
Devatam, at this point, what would your differentials be? Just summarize your positive findings and till now the positive history, and with based on that, what would your differentials be?
when the patient present
एक
and
और
the
होगा एक ही स्ट्रिप है
pardon, ma'am?
Somebody else spoke. You carry on, please.
Uh, he had episode of he had complaint of headache and vomiting actually, ma'am. And he is a known hypertensive patient with this kind of and drowsiness. So we have to rule out any cardiovascular event is there or not, like ischemic CV or ICH. We have to keep in mind about subarachnoid hemorrhage also. He is a known alcoholic, so that could be a cause of alcohol-related any withdrawal syndrome happening or not, or hypoglycemia is there. There could be a meningitis, though there is no history of fever as such. We have to keep in mind any traumatic head injury is there or not. That could be a cause.
What is the typical nature of this headache?
He is a severe thunder from like thunderclap headache happening in subarachnoid hemorrhage,
Associated
ma'am.
with?
With photophobia, nausea, vomiting. Uh,
No, his presentation is the worst headache of his lifetime,
of his
not
life.
subsided with any kind of analgesia, and then he's had a vomiting. So what are we dealing with here, generally, broadly speaking? You said one thing, cerebrovascular event has happened with features of raised ICP. All right.
Yes, ma'am.
You agree with me?
Yes, ma'am.
Okay. Now carry on with your finding.
तूने अपना डब्बा रख लिया है
At emergency department, he was found unresponsive and had bradycardia. Heart rate was around 38 to 40 per minute. BP was little higher side, 180 by 90. saturation SpO2 was 90% at room air. But while assessment was going on, patient through a seizure episode of GTCS, which was immediately managed with IV lorazepam 4 milligram and injection levetiracetam 1.5 gram IV over 30 minutes.
अरे तापस चाय रख दी क्या बोलो तूने
Patient was intubated in view of low GCS and the seizure along with low SpO2. And then intubate the patient and put on invasive ventilatory support. After initial stabilization, patient was shifted radiology equipment for CT scan of brain and then shifted to ICU around 4:30 a.m. in the early morning. In ICU, he was put on invasive ventilator support. At this time, his GCS was low, E120 M1, but during intubation, they are giving some sedation and paralytic agent. So low GCS, exact GCS or sensorial status unable to assess at that point of time. Pupil was bilateral 3 millimeter and sluggishly reacting to light.
Okay, Devatam, are there any red flags from your ED finding that would affect your ICU management?
Ma'am, he has a bradycardia, so there is chance and high ICP might be rise along with hypertension, so pushing triad then that can be a cause of high ICP. And there is episode of seizure, so there is chance of recurrent of seizure also. Patient is drowsy, so everything is on negative side actually. All our
Very good.
things are
So there are what you correctly said, Cushing's triad, very significant. So very probable that ICP is raised. Second thing, desaturation, 90%
yes,
on
ma'am.
room air. That gives you a differential of what? What might we dealing with?
There is during transport patient become drowsy actually, so there could be hypoxia or aspiration that could be along with the cardiology and say CNS effect.
With relevance of SAH, why would you have desaturation? Can you give me two specific differentials? Neurogenic pulmonary edema, possible.
Yes, ma'am. Neurological edema can be.
Also, he may have a Takotsubo from the hyper.
Induced cardiomyopathy.
Yes, and that could lead to a proper cardiac failure. So
Yes.
both of these could lead to desaturation. And you rightly picked up the fact that he has seizures. Is anti-epileptics routinely advised for subarachnoid hemorrhage?
Yes.
There is no prophylactic anti-epileptic for subarachnoid hemorrhage, but if there is a seizure is there, then we can give anti-epileptic until
Yes, you're very
the
correct.
course
So
is
now that you
secure.
have a history of seizure in your ED, you have to give anti-epileptics and it has to be continued. This is not a
Right.
secondary measure anymore. It's not a prophylactic measure anymore. You have to treat for it. As you discuss, we will discuss further about the seizure episode, how it will affect us later on. Continue, please.
ICU patient BP was found 150 by 90. Pulse rate was 58 per minute. Temperature was normal. SpO2 was 97% on volume control ventilation with tidal volume of 420 ml, PEEP of 5, respiratory rate 80 and 40% FiO2. And there was no pallor, icterus, cyanosis, clubbing, and lymphadenopathy. ABG in ICU shows pH of 7.36, PCO2 37, PO2 98 with FiO2 40%, bicarb 18, lactate 2.64, CBG of 164 milligram per DL. Other system, respiratory system, cardiovascular system, and
मेरे कमरे में रख दे
abdominal
पंखा
system
बंद
does not
करके रख
show any significant abnormality. Routine investigation was sent, and CBC, LFT, renal function test, coagulation profile was within normal limit. He had sodium on lower side 134 and potassium is 3. ECG shows sinus bradycardia. Apart from that, no other changes were seen. 2D echo was within normal limit and his serology was non-reactive. CT brain was showed modified Fisher's grade 4 acute subarachnoid hemorrhage, predominantly in the anterior interhemispheric fissure, bilateral sylvian fissure, cortical sulci, basal cinctron, along with acute intraventricular hemorrhage involving all four ventricles and diffuse cerebral edema. So,
Why did you say grade 4 modified Fisher?
ma'am, grade 4 modified Fisher grade 4, ma'am, is a when the IC subarachnoid hemorrhage, thick subarachnoid hemorrhage along with IVH presence, and then it is called grade 4 modified fissure.
Is thickness objectified? Is there a cutoff?
Pardon, ma'am?
How thick should the parenchymal hematoma be to say,
Means
sorry, not parenchymal hematoma, subarachnoid
affected
hemorrhage
more,
B?
for thick, it will be more than 2 cistern to be affected, and thickness will be more than 3 millimeter in the shortest dimension in CT scan.
Correct. So why was the Fisher grade modified at all?
The initial Fisher grade was, ma'am, grade 1, 2, 3, 4, and there is blood clot presence or not. It was a little complicated, and modified Fisher grade is easy to
Simply
practically
put,
applicable, and most probably, as far as I remember, not original Fisher grade and 2 and 3, there is a discrepancy between cerebral vasospasm. Actually, Fisher's grade was uh, done to in prognostic, not for clinical outcome, but for the for chance of vasospasm, risk assessment of risk of vasospasm is there or not. In
yes, you're absolutely right. Based on the older Fisher classification, the incidence of vasospasm was higher in grade 2 than grade 3. And
is
so it was modified. And what is the most biggest risk factor for vasospasm according to this Fisher's grade? What radiological finding is the biggest risk factor? The IVH. So there is a greater importance to IVH now rather than thickness of the blood in the arachnoid space, subarachnoid space. So, you correctly said this is grade 4. What are the other classifications you know of?
This one, there is a Hunt and Hess grade that is on clinical, based on clinical outcome. And apart from that, there is a WFNS scale, grading surgical grading scale. And there is Vanguard scale. And another one is College fee. Just forgot the name.
World Federation of Neurosurgeons, WFNS. So
Is
what we use now is in clinical practices, WFNS and modified Fisher. Why has Hunt and Hess gone out of practice? I mean, it's not popular so much now. Why?
subjective, and it was used to intend to surgical guide the surgical outcome actually. But nowadays the surgery also we will not there is other option apart from surgery, so that's why and is still not popular nowadays.
Also, it was highly dependent on the patient's
Subject,
symptomatology.
symptomatic,
So,
subjective.
objective recordings were much less. It was very dependent on the subjective assessment of the headache. What is WFNS dependent on? How is the grading
It
in
is
WFNS done?
motor deficit and it depends on GCS, ma'am.
GCS and
Motor deficit, ma'am.
yes. So that becomes very important how the patient is clinically presenting. So depending upon the clinical presentation and the radiological findings, WFNS and modified patient gives you a very good risk factor assessment. Grading assessment to prognosticate the patient. All right.
Yes, ma'am.
Please continue.
So in view of the finding and clinical condition, external ventricular drainage was placed and CT angiography was done. Now, CT angiography shows rupture of right-sided ACOM aneurysm. So on next day, endovascular coiling was done. Patient remains critical for next few days. His disease was E1 VT M2 to 3, M2 most time. Pupils were very sluggish and reacting to light, but equal in size, bilateral. On 20th of July, a surgical tracheostomy was done and left-sided PIP shunt was placed. Actually, ma'am, there is a multiple complication happened with the patient, but as I'm not discussing complication, I have not documented all rest of the finding. In fact, patient developed some infection. He is still in our hospital actually with tracheostomy status and poor. Still now his disease is low, ma'am.
So one question here. EVD was placed before coiling the ACOM or was it placed afterwards?
Yeah, first, ma'am, EV was done. EVD was placed, and then coiling was done.
The question is open to anyone who can answer. Is it safe to place EVD and then wait and see for improvement in sensorium and then go for actual definitive treatment of coiling? What does the guideline say?
Ma'am, generally coiling is done first, and afterwards, if there is any kind of bleed, then the EVD drain is put.
Why
It
so?
is
What is
better
the
to
harm?
go for endovascular coiling first, because it can lead to rupture. If there is an unruptured aneurysm, it can lead to rupture if we put the EVD prior to coiling.
Yeah, so putting an EVD brings about a very drastic change in ICP very quickly, and that shift in pressure could lead to rebleed. And what is the risk of what happens with each rebleed? What is the risk of a bad outcome? Per day, with each passing day,
Risk of mortality increases, ma'am.
yes, it is the risk of mortality, nothing
Hmm.
short of mortality. It is not hospital stay, ICU stay, vasospasm, nothing. It is simply mortality.
Yes,
Each
ma'am.
rebleed, it increases several folds. First day, it is, I think, some threefold. I'm not sure of the numbers. You should look at it. It's important. But it keeps increasing. So, rebleed at any cost should be prevented. And that is why the dictum of anyone with a ruptured aneurysm should not see the same day sunrise and sunset without the aneurysm being definitively treated. Basically put together, the aneurysm should be coiled or clipped as soon as possible. That is the dictum of management of aneurysmal subarachnoid hemorrhage. Carry on.
Yes. Subarachnoid hemorrhage, as we know, it is a life-threatening condition, and from accumulation of blood between arachnoid and pia mater, and it is devastating in clinical event and substantial mortality and high morbidity among survivors. From epidemiology around the world, Japan and Finland have the higher cases of subarachnoid hemorrhage, and is more prevalent in Black and Hispanic population than the white Americans. Etiology, we can divide etiology into aneurysmal subarachnoid hemorrhage and non-aneurysmal subarachnoid hemorrhage. But aneurysmal subarachnoid hemorrhage is much more common among spontaneous. 80% of spontaneous SAH due to aneurysm rupture, and is commonly seen in basal cistern region. 80 to 90% cerebral aneurysm are located in the anterior circulation of the brain, that is internal carotid artery, anterior and medial cerebral artery and their branches, and only 10 to 20% in the posterior circulation, like vertebral, basilar, and posterior cerebral arteries and their branches. So broadly, we have divided aneurysm into five parts, five types: saccular, that is the Bayes aneurysm, fusiform, diffuse, globular, and mycotic aneurysm.
So where exactly in the vascular structure do you see the aneurysm, common occurrence of aneurysm?
In the
If you take a
internal
blood vessel,
junction,
no, I'm not asking you the name of the vessel. You take a vessel and its branches. Where anatomically are you likely to find the aneurysm?
there is a junction between two arteries
Yes.
because of turbulence.
Why? Why so?
Pressure
Because the flow is most turbulent
flow,
there.
turbulence.
So, yeah, that is what causes the occurrence of aneurysm. Yeah, please continue.
And plus the tunica media, that is the middle layer of the vessel, is thinned out there. That is one thing we should remember. Yeah.
Thank you. Carry on.
Is the circular wheels for better understanding. So, as we know, the two vertebral artery join together from the basilar artery, and it again divided and give branches to the pontine arteries, and ultimately divided into posterior cerebral artery. Just below the posterior cerebral artery, there is superior cerebellar artery actually. Whereas internal carotid artery divided into two is middle cerebral artery and anterior cerebral artery. Both anterocerebral artery is communicated with anterior communicating artery, whereas posterior communicating artery actually connects the anterior circulation and posterior circulation, uh, and this is the way the circular wheel is formed. Now, apart from non-aneurysm bleed, there could be vascular malformation in form of arteriovenous malformation or dual arteriovenous fistula, cavernous malformation, capillary telangiectasis, etc. And CT angio is the diagnostic tool for diagnosis of vascular malformation. Perimesencephalic subarachnoid hemorrhage can also causes of 10% of non-aneurysmal subarachnoid hemorrhage. Spontaneous rupture of small perforating arteries or veins at the surface of the brainstem. Midbrain usually involved, and the key is the blood does not extend into the sylvian fissures or intrahemispheric fissures. So that is how we can diagnose perimesencephalic SAH in CT scan. It has a comparatively good prognosis and benign in nature. Intracranial arterial dissection is the most common in the vertebrobasilar circulation, and it can lead to subarachnoid hemorrhage. Head injury is another cause of another common cause of subarachnoid hemorrhage, but in that case, cortical region and peripheral part is more commonly affected rather than fetal system. Some drugs like cocaine, sympathomimetic methamphetamine, this can also causes the subarachnoid hemorrhage by severe cerebral vascular. There is some rare cause like cerebral amyloid angiopathy, cerebral venous thrombosis, sickle cell disorder, Moore disease, cerebral vasculitis, and bleeding diastasis. And this can also lead to rarely subarachnoid hemorrhage. Now come to the risk factor. We have divided the risk factor into non-modifiable and modifiable. Among non-modifiable risk factor, age is the most common. Age, I mean, more than 55 years age or more is the risk factor for subarachnoid hemorrhage. Females are 1.5 to 1.6 times more common than male. Subarachnoid has been seen. A past history of subarachnoid hemorrhage itself a risk factor for it. Family history prevalence is 2 to 5 times greater in past degree relatives. Personal history, particularly polycystic kidney disease, Ehlers-Danlos syndrome, is a risk factor for subarachnoid hemorrhage. Size of aneurysm more than 7 millimeter, 5 to 7 millimeter is formed for rupture of aneurysm. There is some few modifiable risk factor also. Smoking is one of the most important, and our patient to have the this risk factor also. He was also hypertensive. It is a risk factor. Alcohol intake. around 30 gram daily alcohol intake is associated with Sagarna hemorrhage. Heavy, moderate to heavy alcohol intake is associated with itself independent risk factor for Sagarna hemorrhage. And as I told earlier, drug abuse, particularly cocaine abuse, also are prone for developing subarachnoid hemorrhage. So five broad tribes I just told little earlier: saccular, fusiform, dissecting, globular, and mycotic. And as ma'am told, true aneurysm have all three layers, and like tunica, media, intima, and adventitia. But what is pseudo aneurysm? And this picture over here actually, and is a result from tear or injury and blood leaking out, forming a pulsatile sac covered by the coagulation factors. So it is not the origin true aneurysm. True aneurysm covered by the all normal layers of blood vessels. Now grading, Hunt and Hess grade, it is the oldest one for prognostication of subarachnoid hemorrhage, and it is a clinical grade. In 1968, actually, it was the timing when the grade was incorporated. Initially, it was 1 to 5 grade actually, and later Hunt and Kosnick added 0 and 1A grade. Zero is unruptured aneurysm without any symptom, and one is asymptomatic or minimal headache with slight focal rigidity. It is mortality rate is 1%. 1A associated with no meningeal or brain reaction, but with a fixed neuro deficit. 2 is moderate to severe headache, no neurologic deficit other than cranial palsy. 3 is drowsy, confused with mild focal deficit. Mortality is 19%. Grade 4 is 2 for moderate to severe hemiparesis, possible early cerebral rigidity, and vegetative disturbance. So its mortality rate around 42%. Grade 5 is 77% mortality rate. It is a moribund patient, decerebrate, and deep coma. The modified Fisher scale of subarachnoid hemorrhage, it is CT based on CT finding. It is grade 0 to grade 4. Grade 0, there is no SAH and IVH. Grade 1 is, as I told earlier, focal or diffuse but thin SAH with no IVH. The symptomatic vasospasm chance is 24%. Grade 2, grade 1 and grade 2, that is both a thin SAH. In grade 2, there is IVH present, and grade 1, no IVH. Chance of vasospasm in grade 2 is around 33%. But grade 3 and grade 4 is thick ICH, and the higher grade, the chance of that IVH present is the higher grade. In grade 2 and grade 4 as IVH presence. So in the grade 4 is thick ICH, SH and IVH, and the incidence of symptomatic vasospasm is around 40%. So our patient had modified, as per modified Fisher scale, our patient had grade 4 of SH. So this is the CT scan finding of and grading of modified Fisher scale as well. This is WFNS score, World Federation of Neurosurgeon score for subarachnoid hemorrhage. It is the one of the most commonly using grade. It has divided into grade 1 to 5 based on GCS score and motor deficit. And grade 1 is 15 GCS with no motor deficit. Grade 2 is 13 to 14 without motor deficit. Grade 3 is 13 to 14 with motor deficit. So this is about the GCS scale as same, but one having motor deficit absent and another is motor deficit with motor deficit. Whereas grade 4 and 5, motor deficit is not important. May be present, may be absent, but GCS is the priority in these cases. Grade 4 is 7 to 12 GCS score, and grade 5 is 3 to 6 GCS. Based
No,
on GCS,
Devatam, I would fear to disagree with you there. GCS along with deficit is what makes it so useful in management. So it is not that GCS is more important than deficit. You look at 2 and 3. Both are same GCS. Only difference is you have a deficit. So grade 3 onwards, you have deficit. So deficit
yes,
is
ma'am.
equally
I
important.
for 4 and 5, ma'am.
Okay. You also have a question in the box asking what is thick and thin SAH. Can you define that, please?
Yes, ma'am. The thick is more than 2 cisterns and more than 3 millimeter in CT shortest dimension in the CT scan. That is the thick SH, ma'am.
I hope that answers your question. Carry on, please.
So next is Vasocrate scale. This scale was incorporated by American Heart Association and American Stroke Association and developed to predict this delayed cerebral ischemia following SAH. Patient classified as green and yellow and red. And green has the 100% sensitivity when present in green is incorporate WFNS and modified feature scale and 1 to 2 and 1 to 2 of both scale. Yellow is 1 to 3 and 3 to 4. They are divided like that way. But we have seen the green having the uh, low risk for developing DCI compared to patient classified as red. Sensitivity is more with green and specificity is more with red.
What did you say was
And
the purpose of this classification, Vasograde?
delayed cerebral ischemia.
Yeah, but
Develop,
it was specifically developed to decide about the intensity of monitoring in the ICU. Delayed cerebral ischemia is the eventual result you will get, but the whole purpose is how long, depending upon the severity of SAH, should you keep the patient in ICU and how often should you be doing TCD. That was the purpose of this Vasograde, and that is why these three traffic light kind of differentiation is given. Carry on.
possibly add Carter grading system to predict outcome of surgical management of intracranial aneurysm. So the main parameters age, Hunt and Hess scale, and Fisher scale and aneurysm size. So Hunt and Hess scale help to assess the clinical condition, where the Fisher scale estimate the subarachnoid hemorrhage volume and the vasospasm risk. So it has total score ranges from 0 to 5 and grade higher the grade, higher uh, chance of mortality, higher the poor prognosis. So age is less than 50 or more than 50. Hand and head scale 0 to 3 or no comma, it is 0 point. Or if there is a patient is in coma or grade 4 to 5, then it is grade 1, like that way. Similarly, Fisher score 0 to 2 and Fisher scale 3 to 4 and within say 10 millimeter or less or posterior circulation aneurysm site 25 millimeter or more. Like that way, they have divided 0 to 5 grade, and according to that, they have come to conclusion.
So Devadam, there is a question in chat box. How is the sensitivity and specificity given for the Vasograde?
Pardon me, I'm repeating.
ये मैंने बैक वाला वो लगा लिया ना इसमें तो हाँ सही है स्ट्रेस नहीं है पूरी बॉडी में लगाया आगे पीछे होते हैं क्या दिक्कत है पता
The question is in Vasograde, how is the sensitivity and specificity taken?
इससे वाला नहीं है ये वाईफाई वाला सिम कौन डाले इसको थोड़ा आपको यूज करना है नहीं तो दोनों तो पढ़ाई के पर्पस से दोनों
Swati, can you please mute your mic? Non-speaker, please mute your mic.
नहीं वो ऑप्शन रखना वो होना चाहिए था ऐसा होता है ये केवल पढ़ाई के पर्पस से है
Dr. Neeraj, your mic is please.
All right. So basically, the sensitivity and specificity is for the basically how it is done. I will not be able to tell you at the drop of my hat. I can put it in the group tomorrow. But basically, in the severe grades, the chances of DCI detecting DCI depending on Vasograde is higher, and so it tells you to keep the patient in the ICU for a longer time and do almost every 8 hourly. You have to do the TCD. I can put the article in the group. Tomorrow I'll put it. Please carry on.
Now, this is the diagnosis, and it depends on the clinical, how to diagnose the subarachnoid hemorrhage depending on the clinical examination. There is Ottawa SAH rule, and for alert patient more than 15 years of age, and non-traumatic headache, which is typical suggestive of subarachnoid hemorrhage reaching maximum intensity within 1 hour. Then we have to suspect subarachnoid hemorrhage if the patient age is more than 40 years and there is a neck pain or stiffness, witness loss of consciousness, onset during exertion, and thunderclap headache, and the limited neck flexion on examination.
What is the role of LP in detecting SAH?
If CT scan is inconclusive or not suggestive of subarachnoid hemorrhage, but clinically we feel very high suspicion of subarachnoid hemorrhage, then a lumbar puncture is recommended, ma'am.
What do you look for in the lumbar puncture?
Uh, there is a xanthochromia, presence of bilirubin in CSF because of
Excellent.
denervation of
That is where your Hunt and Hess classification comes in with grade 0. Good. Continue, please.
diagnosis primarily done by NCT brain followed by CT angiography. And a small percentage of cases not diagnosis in initial angiographic studies but may be identified on repeat angiography and classified as Coffert aneurysm group. The reason are technical or reading error, small size of aneurysm, or obstruction of aneurysm because of the vasospasm, hematoma, or thrombosis within the aneurysm. CT scan have
What is
high
the
sensitivity.
role of CT perfusion? Again, in vasospasm. So, depending upon the mean transit time and the basically mainly dependent on the transit time and latency. There's another word for latency. Between these two, you will be able to diagnose a vasospasm much before DCI comes in and also before the TCD findings are available to you. Carry on.
CT brain has 100% sensitivity for first few hours, 6 hours to 24 hours, but comes down 50% after 5 days. Early CT scan is recommended as it has 100% sensitivity. MRI, FLAIR T2 image, gradient radiant GRE sequence are useful for the diagnosis. If initial CT scan is negative, lumbar puncture is performed. In case of strong suspicion, a lumbar puncture should ideally performed after 6 hours of initial CT head to detect presence of xanthochromia. Uh, Digital subtraction angiography DSA of all cerebral arteries to be performed in bleeding sources not found in CT angio, or if the patient has atypical basal SAH pattern on CT for diagnosis and planning of the treatment. So DSA is the gold standard actually. Time of flight magnetic resonance angiography is another acceptable mode of imaging that does not require any contrast injection.
How does that help in management? So basically, for the IR team, interventional radiology team, to decide this risk that during coiling it may rupture. Okay. So what are the bases on which the decision about coiling versus flow diverter? I'm not talking about clipping. Coiling, clipping, there's almost hardly any difference right now. But if you had to decide between flow diverter versus coiling, what are the factors in favor of flow diverter?
Size of aneurysm and neck, weight of neck of aneurysm. I'm not sure.
Why so?
Because if it is larger in size, then coiling will be difficult. Multiple coil have to be used, and that is
Excellent.
technically difficult.
Financially difficult, and you will require many coils. So there is a complication risk is also high. So you would put a flow diverter there. What is the problem with flow diverter? There you need a time of flight images to really describe the anatomy of the vessel so that they can plan how it is to be placed. Okay. Also, number of coils to be, if the coil is the only way to go, number of coils to be placed, they decide upon the, based on the anatomy. So in that, TOF helps, and given the fact that you don't need any contrast. Carry on, please.
Now treatment. So treatments start with airway, breathing, and circulation. Treatment of seizure. As our patient had a seizure, we have to treat the seizure at least until the aneurysm has been secured. And nowadays, euvolemia is recommended rather than hypervolemia. Electrolyte correction to be done. Our patient has sodium of 134 and clinically suggestive of high ICP. So we have started with 3% NaCl to counteract that. Avoid hyperpyrexia or pyrexia. Avoid both hyperglycemia and hypoglycemia has been
What,
recommended.
sorry, Devatam, what was your sodium target when you started 3% saline?
Our patient, ma'am, 134 sodium was there. So we try to keep it on higher side, ma'am.
Higher means how much? You have to have a target.
150, 150, around 150, ma'am.
Safer is 140. There's no guideline as such, but most of the articles mention at least 140 should be maintained. Yeah, carry on.
DVT prophylaxis, European Stroke Organization recommends to start LMWH within 12 hours after surgical occlusion of the aneurysm and immediately after clipping. Uh, but I read in American Heart Association, they are recommending after 24 hours of procedure to start
That's
DVT
true.
prophylaxis.
That's true.
Bed rest and stress control is also recommended.
So in Triple H, which H is still applied?
Hypertension, BP to be kept on higher side.
What is the limit of higher again?
Actually, there is most probably there is no exact target of blood pressure to be kept, but around 160 millimeter of mercury of systolic blood pressure is usually followed and treat.
So here there is no guideline, as you said, but if your patient is amenable to clinical examination, there is no limit. You have to keep raising the blood pressure until the clinical deficit improves. So if the most subtle sign that there is a vasospasm or DCA setting in is probably a pronator drift. So suppose it's an ACOM aneurysm and the patient has a left pronator drift. You will keep raising the BP until that pronator drift settles down. The other endpoint would be if the patient develops some STT changes on the ECG or starts to develop a cardiac complication like a congestive cardiac failure. So there is no, you have to go to the extremes. There is no numerical limit to how high you can build up the BP. All right? Continue.
So in general management include medical measures and intervention options like endovascular coiling or direct surgical clipping. Patients are typically treated with both medical and intervention options. More conservative or less invasive intervention may be sufficient for patients with grade 1 or grade 2. But the key goal of all SAH patients are prevention of rebleeding, delayed cerebral ischemia, supportive care, pain management, and accurate diagnosis and treatment. For analgesia, non-opioid medications such as acetaminophen are the first line of medication and administered every 4 to 6 hours. NSAIDs like aspirin should be avoided until aneurysm is secured. Opioid medications such as fentanyl.
Hold on a minute. 2 questions here. First one, what is the latest about analgesia that has come up for ablating pain in subarachnoid hemorrhage? Question number 1. Question number 2, where do you have to give antiplatelets? Mandatory part of management. There are ganglion blocks that are being used. The subarachnoid hemorrhage pain is very, very severe, and that pain could be a cause of vasospasm as well. So at any rate, you have to reduce that. Many a times analgesia will fail. So there is ganglionic blocks that have been tried. I think one of the stroke papers itself says about that. That also I can post you tomorrow. Second thing is where flow diverters are placed, you will have to give dual antiplatelet. Otherwise, the risk that it will thrombose off is very, very high. Carry on.
Opioid medications such as fentanyl 12.5 to 25 mics IV every hour is needed. Morphine sulfate 2 to 4 milligram IV every 1 to 2 hours as required may provide pain relief as well as a degree of sedation and serve to decrease anxiety. But patient response to pain medication must be monitored closely to avoid over-sedation and inability to accurately assess the patient neurological status. Pain management is essential, but with caution so that worsening in the neurological status is not masked. Now, blood pressure control, blood pressure should be critical to reducing risk of rebleeding until the aneurysm is secured and during first 24 to 48 hours post-operative period. But most probably this is wrong thing. As I told ma'am, as you have told, it is kept on the higher side. There is no limit of keeping blood pressure on higher side
Any
until there
drug
is a
that has been used to prevent rebleed? Any trial you know of?
bleeding.
Tranexamic acid has been tried. It
Yeah,
has
but
reduced, it is known to reduce the risk of rebleed, but at the cost of thrombosis. So it's not clinically very popular.
ultra trial for
Yes.
tranexamic acid.
Yes.
Nitrate and nitroprusside we not use for a first-line agent and it causes cerebral vasodilation and increase the ICP. So, labetalol beta blocker may be administered over 2 minutes in doses ranging from 5 to 20 milligram IV every 15 minutes. 20 mg IV bolus over 2 weeks followed by infusion, maximum 160 mg per hour. Labetalol IV bolus can be given directly, but for infusion, it has to be directed. Hydrogen is
Again,
given.
again,
Yes, ma'am.
Devatam, clinically, if on day 5, day 6, BP is climbing up, will you readily go and try and reduce the blood pressure? You have to take the clinical perspective. So day 4, day 5 is the time where post-ictus would be the time where vasospasm is setting in. And the high blood pressure could be the sympathetic response to preventing any ischemia coming from vasospasm. So you go ahead and give all these IV labetalol and try and reduce the blood pressure, you'll end up having infarcts. But on day 1, you cannot have a high blood pressure. So you have to, the BP reduction and use of antihypertensives have to be taken in perspective of what the clinical situation is at that time.
And
All right.
condition of the patient.
Continue.
Hydrogen is given incremental dose, IV dosage 20 to 40 milligram every 30 to 60 minutes. Uh, but hydrogen is a arterial dilutor, so we can give this hydrogen, not the nitroside. Oral limodipine is given low dose of 60 milligram every 4 hours or 30 milligram every 2 hours for 21 days. So limodipine is the choice to prevent the vasospasm. We have to correct coagulation abnormality if there is present, and the ultra trial for tranexamic acid in subarachnoid hemorrhage. And the ultra early short-term antifibrillary therapy did not show any significant reduction in the rate of rebleeding, no improvement of functional outcome at 6 months. Moreover, rate of excellent functional outcome was actually lower in the tranexamic acid arm. But AHR ASA concludes that it is a not useful part of routine management, but there is a possible role of it in setting where the aneurysm obliteration will be delayed beyond 14 hours from the symptom onset because of the logistic or other medical reason. So, any setup where there is an intervention radiology or surgery is not possible, in that case, for within 24 hours, we can use tranexamic acid to prevent the bleeding. Treatment of aneurysm, and that is the endovascular coiling or surgical clipping. Uh, it is recommended to done as early as possible, preferably within 24 hours of the onset. This is a true trial, RAT and ISAT trial, and showed that endovascular coiling has a better functional outcome at 1 year, but rate of obliteration is more with surgical clipping. Actually, there is no one superior than another, and depends on the team, depend on the presence of intervention radiologist or neurologist or the patient. Bulk of the confidence of the surgeon or the team. That depends the whether go for endovascular coiling and surgical clipping, and the condition of the aneurysm, what is the surgically accessible or endovascularly accessible or not, all these things. Primary coiling is preferred for posterior circulation and internal carotid artery aneurysm, whereas clipping is superior in the wide. Pardon?
Concern what difference it makes to us while managing the patient if the patient has had coiling versus clipping.
Coiling, ma'am, there is a chance of vasospasm rebleeding is there is a comparatively more rather than surgical clipping. But surgical is open surgical technique, and uh, many a time it is not accessible for the surgeon. Uh, that in that case, surgical coiling is
No,
recommended.
that doesn't bother us, the intensivist. No. What management has been undertaken, how does it make a difference to us in managing in the ICU?
Coiling and clipping, between coiling and clipping. So we have to coiling. There is a chance of infra and all these things can be happen after coiling. So we have to close monitoring of this type of complication. We have to keep in mind if it is undergone endovascular coiling.
One thing is coiling lead to bilateral. You cannot insunate on one side and say no vasospasm. You have to make sure that you do it on both sides. Ideally, you should always do on both sides, but definitely when it is clipping, you should do it, and you will be very likely finding vasospasm on the contralateral side. Another very important thing is patients who are coiled, soon after they come from the procedure, there could be a precipitous drop in blood pressure, especially if they've had a flow diverter placed. There's a rapid decrease in the pressure head, or it will be very volume sensitive. So you hydrate and the pressure comes up. These are two very important things for us in the ICU. Continue.
But and that's all one for management of subarachnoid hemorrhage. That's all.
Yeah, that was a very nice presentation. Thank you very much. Anybody wants to ask any questions? Please go ahead.
Doctor, can you elaborate other complications related to SH specifically on presentation?
Sushma, there's another class 2 weeks later on complications.
Yeah, okay. Thank you.
Fellows in the group, either you've understood the subject very well, you don't have any questions. I would like to believe that.
Ma'am, could you please repeat the difference between coiling and clipping in terms of intensivist perspective? I didn't get because of the sound was cutting.
Okay. So basically, when you have a clipping done, the surgeon has blood in bilateral field, and there are chances that perforators on the contralateral side may also be handled during the surgery. So in the end result, there is a high chance that you may have vasospasm on the contralateral side also. So when we are dealing with vasospasm or the doubt of vasospasm, you should do TCD bilaterally. Ideally, you should be doing TCD on both sides, but when it is a case of clipping, you should definitely do on the either side, and you may be very likely getting vasospasm on the contralateral side. That is one thing. Coiling also leads to, especially when you place a flow diverter, you may get precipitous decrease in blood pressure soon after the procedure. So there is suddenly a large blood vessel has opened up and the blood flow gets transitioned to that area, there is a relative hypovolemia. And this can lead to drop in blood pressure, which can lead to ischemia. So this is very volume sensitive. So you may end up giving some fluid boluses to build up the blood pressure, and you may transiently need inotropes to build up the blood pressure. And it wears off pretty quickly also. All right, any other questions?
And ma'am, chances of thrombosis are more in which treatment, boiling or clipping?
Thrombus is more likely in coiling. That's why you have to, especially with flow diabetes, you have to give double antithrombotics.
Okay, thank you.
Anyone else? If not, Debatam, very good beginning, fantastic class. You have several more to go in your 1-year fellowship. Thank you very much. I
Thank
think
you.
someone has put
Thank you.
a question right now. 1 second. What increases occurrence of vasospasm? Presence of thick SAH or IVH? It is IVH, and that is why the Fisher's grading was modified. The thickness of SAH is not related to vasospasm. Presence of IVH is. All right, Debatam, thank you very much.
Thank you, ma'am.
Good night, everybody. Lively class once again. Let's keep it up. Thank you.
Right, ma'am.